Well, good morning. We will go ahead and call our meeting to order. This is the May meeting of the Commission to Combat Substance Use Disorder. Thank you all for being here. The minutes were distributed prior to the meeting. Does anybody have any changes? Otherwise, I'll entertain a motion.
So moved.
Second.
Great. All in favor?
Aye.
Thank you. The minutes from the February meeting have been approved. I want to start by inviting members of the Commission to the Indiana Mental Health and Addiction Conference on June 27th and 28th at the Indiana Convention Center. It's hosted by the Division of Mental Health and Addiction, Next Level Recovery, and the Indiana Recovery Alliance. The conference combines several meetings that have normally taken place over the course of the year and combines them such as like In Arms or the Peer Recovery Conference. And the aim is to help integrate those working in the mental health and addiction fields to have a more holistic conversation around both of the subjects. And so over the 2 days, we'll highlight innovative approaches in prevention, treatment, and recovery. Information should be included in your folder, and we'll send out a registration link following today's meeting. At the end of the meeting, I'll also give an update on opioid settlement funds and the matching proposals that were submitted in February. So now it is my pleasure to introduce our recovery speaker, Jennings Tenery. Last week at Overdose Lifeline's annual breakfast, I heard Jennings speak about her recovery and the impact on her family, but most importantly, her son and his experience at Camp Mariposa, where Overdose Lifeline is helping to break the intergenerational cycle by mentoring youth who have been affected by a family member's SUD. So welcome, the floor is yours.
Thank you. Can you guys hear me? Yeah. Hi. So in the past two and a half years, my typical introduction starts off with, hi, my name is Jennings, and I'm a recovering heroin addict. It took me a long time to find recovery and what that looked like for me. I spent a lot of years in addiction and a lot of years searching for sobriety. When I finally did find that, I was on fire for it, really. I couldn't get enough of it, and I just automatically assumed that everybody around me was going to be magically better as well. So granted, my mom, my dad, my brother and sisters, and even my husband, they took a hard hit with my addiction, but my 10-year-old son, Gerald, took the hardest. So what I did to Gerald in my addiction was I isolated him. He wasn't welcome to go to school and talk to his counselors about what was going on at home for fear of getting me in trouble or getting taken away from me. And sadly, he couldn't even talk to his best friend about what was going on as well, because the stigma around addiction is so profound that even a child recognizes it. So I got in recovery, and I knew that Gerald needed some help. The reason I knew that is because he still had the same fears, the same nightmares, the same anxiety as he did when I was in addiction. So, example, he still questioned on whether I was going to pick him up from school on time or just altogether forget. He would still ask me what my contingency plan was when I would relapse or go back to jail and he had to live with a family member. Who was he going to live with this time? But the hardest one for me, the one that I still have a hard time verbally admitting and didn't actually do so until last week, was Gerald would still ask me to keep the bathroom door open every time I used it for fear of me overdosing or relapsing. A child is not meant to carry the weight of a mother and father's addiction. They're just not meant to, but unfortunately, they have to. And so, again, like I said, I knew I needed to get Gerald out of that isolation and quickly, but I didn't know how. So I put him in extracurricular activities like, baseball, football, basketball. I even put him in theater and piano. And while he really liked those things, they did not fill the inner need, the soul-wrenching need that he needed to connect with somebody. And it wasn't until I attended a 12-step meeting one day, and I was sitting in this room, and I was listening to others just like me share their experience, strength, and hope, that I realized in every person's story I heard my own. And in that moment, I truly felt like I connected. I felt like I found my community, I found my people, and that's when I realized that's what Gerald needs. I think, it's our human nature and society that we all need to feel like we belong, whether it be when we start grade school and we look for our first best friend, or high school when we want to join a clique. You know, Gerald, my son, was no different. He needed to find his community, but I didn't really know where to look. Fast forward a little time later, I took a job with Overdose Lifeline, and I learned about Camp Mariposa, and it checked off all the boxes. I asked Gerald, you know, quickly if this would be something he was interested in, and he was so excited. See, the miracle of it is Gerald didn't have to attend Camp Mariposa over and over again before it started to sink in. He was immediately refreshed and felt so good to know that he could go to this camp and share what happened to him with his counselors, and he was in a safe place. He could share it with other kids because they've dealt with the same trauma. They've dealt with the same experiences, and he wasn't going to be made fun of. I think it's so important that we all find our community, but what this is for Gerald is it's going to break the cycle of addiction. I would bet my life on it, whether it be through him or his children. This is where it starts. It starts with our children, and I'm just so proud to be a part of Camp Mariposa and Overdose Lifeline. So thank you for letting me to share.
Well, thank you, Jennings, and sharing your story and reminding us the importance of family in the recovery process. We're a proud partner with Overdose Lifeline to help make Camp Mariposa possible for all kids in our state. So thank you to Justin and Overdose Lifeline for your work. At our November commission meeting last year, we heard from the Dearborn County Sheriff and the local recovery organizations' experience in implementing the Integrated Reentry and Correctional Support Program. And we've invited Jamie Whitaker with the Indiana Forensic Services to share their mid-year results from the program's 5 pilot sites in Blackford, Davies, Dearborn, Delaware, and Scott counties. Spoiler alert, for those, we are currently in discussions about expanding the program into more counties next fiscal year. So we've had countless communities reach out asking how they can bring IRACs to their county, and if we could feasibly implement this program in every jail across the state, we would. But we're taking a thoughtful approach. We want to make sure that every community is ready for the program and that we're developing successful infrastructure as we implement them. So, Jamie, thanks for being here.
Thank you. Chairman, board members, thank you so much for allowing us to be here today to share what we've learned. On behalf of Mental Health America and our IRAC sites, our sheriffs, and our criminal justice partners, it's a privilege just to be here and to share our report with you today. Again, my name is Jamie Whitaker, and for the last year we have been working on implementing the IRACs program in 5 pilot sites across the state. Back in the fall of 2021, we began to meet with DMHA, Next Level Recovery, and discuss some success that had happened in one of our jails at our hubs, and the possibility of implementing or expanding that success into other jails. And those are the early conversations around the IRACs program. In June of 2022, we were awarded Indiana Recovery Works funding, and we did move into launching those sites in early June. When we looked at what were the components that would need to be in a community to make an IRACs program successful, we came up with what we call a readiness assessment. And that readiness assessment, one of the most important components of that is that we needed to have a recovery community organization. And with the infrastructure that has been built with the Indiana Recovery Network and the recovery hubs across the state, that was the first thing we looked at, was looking at those hubs and identifying which one of those hubs would be most likely to be able to house and support an intensive program like IRACs. We looked at sheriff willingness to support recovery in their jails. I mean, obviously, putting a program like this inside the jails, you would need to make sure that you had sheriffs that were recovery focused and had the capacity, they had the space and the ability to house a team and be able to support that team throughout the grant cycle. We looked at city and county leadership and tried to understand where the city and county leaders were, and this idea of really supporting and investing in recovery infrastructure in their communities and how well they would be able to support a program like IRACs. We looked at the criminal justice partners, so our prosecutors, our courts, public defender's office, community corrections, community supervision, and began to do a lot of discussions and interviews and meetings around are the criminal justice partners ready to partner with people in recovery? Are they willing to look at the sequential intercept model and the idea of creating interventions and possible diversions for people who are low-level offenders, level 5, level 6 nonviolent offenders, and look at the possibility of providing opportunities for, rather than being in jail, looking at other opportunities. We wanted to make sure that they had a strong recovery community organization, and it's really important that this was a basis. So the teams were housed at the recovery community organization, and those teams were supported through that structure that had been built through Recovery Network. After surveying about 20 sites and doing ongoing interviews and collaborations and meetings along with IRN, we ended up coming down to a list of about 5 counties. So we launched and signed contracts in Delaware County with Sheriff Tony Skinner and PAST J County Coalition, Scott County with Sheriff Jerry Gooden and Thrive Recovery Community Organization, Dearborn County Sheriff Shane McHenry and Choices CERT and One Voice, Davies County Sheriff Gary Allison and Davies County Peer Recovery, Blackford County Sheriff Jim Heflin, and again J County Coalition PAST Recovery Community Organization. Those were the 5 sites that we chose for the pilot sites. We tried to choose sites that were both rural and spaced out across the state. We tried to look at sites that we knew would be more urban, and that way we could get a better understanding of how this would impact the larger communities and our more rural communities across the state. The infrastructure behind the program, IRAX is built on 3 pillars, and these pillars are the sequential intercept model, and I'm sure many of you are familiar with that. And this is creating interventions across the criminal justice process where we have opportunities to intervene, identify individuals who are struggling with substance use disorder and mental illness, and identify places where we can build collaboration and alternatives and support and resources for those individuals. The second pillar is that the entire teams and everyone who's providing services in the IRAX program, all of the people who are providing services are people in long-term recovery, or someone who's been impacted by someone who has struggled with substance use disorder or mental illness. The third pillar of this is what we call our engagement pathways. One of the sayings that we talk about in IRAX is we talk about rethink reentry and rethinking reentry. And we learned and we knew that going into this, that identifying individuals who are going into reentry and deciding to work with them at that point, that we were too late to be able to really successfully create resources, build a plan, and intervene and provide supports for those individuals if we're waiting until they're getting out of jail or getting out of incarceration to provide that support. So our idea behind rethinking reentry was the idea that we want to start those supports and services from the moment they were incarcerated. So as soon as they arrive at a facility, as soon as they arrive in jail, those services start right then. When we talk about our engagement pathways, I want to go into just a little bit more about what they are. So our engagement pathways, we identify them in 5 different levels, A through E, and each level provides us an opportunity to collaborate with our pre-services court partners and court partners working with the prosecutor and public defenders, and identify what is the likely progression through their criminal justice process that they would have through that collaboration. Once we know what it looks like, we identify them in one of those 5 levels. So the level A's are people who are going to spend a significant amount of time inside the jail. And while they're in jail, we provide a whole host of services, but we know they're going to be in jail for a while, and we know we can support them while they're there. Our level B's are individuals who we know are within the next 90 days are going to go into community reentry. So we know we can begin to plan immediately for those individuals in the reentry. You know, they're higher at risk for getting released, and it gives us an opportunity to get in and start planning right now for those individuals. Our level C's are individuals who usually have higher level charges or more extensive criminal background, and the likelihood that they're going to go to the Indiana Department of Corrections is pretty high. So we have created a process within the IRAX program to provide support, to collaborate with IDOC, provide support for people, and help them plan for what their recovery could look like once they transition to the Indiana Department of Corrections, and then help them make that transition successfully, and then also collaborate with their family members so that they know what to expect during this transition process, and understand how we can support them with their needs while their loved one goes off to IDOC. Our level Ds are probably our highest risk population, and those are the individuals, we call them our frequent flyers. So they come in the jail, they may get arrested on a Saturday morning, and then they may get released after going to court on Monday morning. They may get arrested on a Monday and get released the next day. We normally do not have enough time to work with these individuals, so we want to identify who they are, and we collaborate with our court partners and with our jail partners to say, let's identify the people who are at highest risk for getting released, who are struggling with substance use disorder and mental health. Let's identify who they are. Let's get planning as quickly as possible. If they do get released before we get a chance to engage with them, we want to get them connected with our community partners and try and get them on the radar once they leave the facility. And then our level E's, obviously, people do have a choice if they want to participate or not, so people do have the right to refuse services. I can tell you early on in the grant, we had a pretty significant amount of people who refused services with IRACs, did not want to participate. Most of the people that did so felt that I'm going to prison or you can't help me, there's nothing you can do for me. As the IRACs program progressed, we've seen our level E population drop and drop and drop and drop and drop, and really I think there's less than 10% of the people in the jail who are eligible to participate in IRACs who are actually refusing to do so. When we look at risk management, the idea that we want to increase our protective factors and reduce risk factors, we had 7 priorities going into the program. The first priority is provide an early intake support. So our peers meet with people right when they arrive at the jail as soon as humanly possible and begin to do a whole host of surveys and questions. We look at their history, we look at their clinical history, their criminal history, and a whole host of information about them. And the biggest thing we try and do, as someone who grew up in the system and grew up in the criminal justice system, I can tell you, I can't count on my fingers and toes how many times I was in a courtroom, but I can tell you, I rarely feel like anyone ever really knew my story or really knew what was really going on with me. They knew my charges, they knew what brought me into court, but very few people really knew my story and what I needed in my story. So in that early place, when they arrive at the jail, the biggest thing we're trying to do is get to the story of the individual, find out exactly what they're struggling with, exactly what's causing the struggles, and how can we help change their opportunities so that they can look at their story being different than what it has been. Priority 2 is integrated pretrial and community collaboration. We know that in those early moments of incarceration, those early days after arrest, that there's a lot of decisions that are made around individuals when it comes to how they will progress through the criminal justice process. What we'd like to do is build collaboration to get that story into the hands of the individuals who have the power to make decisions and make sure that those decisions are well informed. Priority 3 is ongoing one-on-one support and group support in jail. So we provide one-on-one support for everyone while they're in the jail, and we provide both substance use disorder groups and mental health support groups while they're in jail. So everyone has an opportunity to get one-on-one with a peer and also get into a group, whether it be SUD or whether it be mental health support. They have those opportunities at all the IRAC sites. Priority 4 was a comprehensive jail-based treatment support, which means we want to collaborate with every partner humanly possible to make sure that as many resources we can get people while they're incarcerated, we can get those engaged now and collaborate with our treatment partners to make sure that there's no place they're going to fall through the cracks. Priority 5 is reentry, recovery, and crisis planning. Everyone needs a plan when they leave jail, and we start that planning process early on after arrival when they feel like they're ready to start thinking about what life looks like outside of jail. We begin that crisis planning and begin looking at their reentry. Once they leave the jail, we meet them at the door, so they do not leave alone. We follow the plan, our peers work with them the first 30 days after they leave, and we help them transition from jail back to the community. And then we hand off to our priority 7 is handing that off to our long-term community partners at the Indiana Recovery Network, so that not only do they have a peer that helps them transition out, but they have a peer that can walk with them forward as long as they need. Our pilot outcomes. We've been really blessed. We had a great evaluator through the program, and we've learned some really great lessons so far through this process. So during the first 6 months of our implementation in the program, we supported 2,004 individuals who were incarcerated in our five pilot jails. And you got to realize 2,004 people out of 3,070. So that shows you how many people didn't participate. And this includes people who are not eligible. So the jail can identify someone as not safe to provide support to, or people who say, I simply don't want to participate. So 2,004 out of 3,070 in the first 6 months. We provided about 3,500 intake surveys, and that's that comprehensive intake process we take people through, getting to those stories. We provided almost 3,000 group engagements, and that's both our RAP groups and our, we call them their matrix groups, our SUD groups. We actually provided 1,063 recovery plans, and so it's really significant to realize that we're planning with all those individuals from when they leave the jail. And probably the thing we're most proud of, with our mature IRAC sites, once a site becomes what we call a mature IRAC site, right now our data is showing we have about a 75% completion rate on the first 30 days after leaving jail. So 75% of the time, we're able to hold on to those individuals or get them engaged when they leave jail and follow the plan that we had in place. When we look at SIM collaboration, sequential intercept model, it's really significant to think about how our collaborations impact our individuals who are in greatest need. Some of the things we learned, and one of the benefits of the IRAX program isn't just that it helps people, but it's really helping our criminal justice partners as well. They really feel like that they're having more impact, that we're able to collaborate more strongly. So when you look at the outcomes, I mean, strengthen communication, coordination, and collaboration with all providers. Some of the more significant things we're probably the most excited about, we didn't plan for these things to happen, but we're seeing a reduction in critical incidents in the jail. So fights, people becoming suicidal. In the jails, people feel like they have access to more services, that people are connecting with them, and that they have support. Some of the things we didn't plan on were correctional staff reporting that their stress levels of the correctional staff has reduced. Increased resources, more insurance. We're making sure that everyone gets insurance when they're in the IRAX program, and that insurance is available to them when they leave, as well as housing, food, clothing, all the things that they need when they leave. And then increased recovery community. The really interesting thing is when you go to these jails, I went to them when we first went out, and it really felt like a jail. And you go to them now, and I would highly recommend going and taking a visit to a pilot site. You go in there now, and it feels like a recovery place. People are in there talking about recovery. Inside the pods, people are hosting recovery meetings. You're seeing a lot more engagement, reduction in stigma, and people saying, hey, I'm struggling, and here's what I'm struggling with. We're seeing all of those things across the pilot sites. As someone who lives with long-term mental illness and struggles with mental illness my whole life, I can tell you that one of the greatest things and things I've been the most excited about through the IRAX program was the Division of Mental Health and Addiction provided us an opportunity to use what's called the CAT-MH survey. And it is an AI-driven survey. It's a self-survey, so basically people answer questions about their mental health, and the CAT-MH actually increases the intensity of the questions depending on how they answer. And then once they get through with that, we're able to get information about anxiety, PTSD, depression, mania, and SUD, which is really exciting data. So when you look, right now we've provided over 1,000 CAT-MH surveys through the process we've done with the IRAX programs. And so we're seeing significant, out of the individual survey, we're seeing 41% present with moderate to severe symptoms of PTSD. A little more than 1 out of 3 participants show moderate to severe signs of mania at 38%, anxiety at 34%, major depressive at 44%, and SUD at 47%. And again, as I said, as someone who lives with long-term mental illness, I can't stress to you enough that doing this program in the jail for the few years that I did it, and then working with our pilot sites over the last year, mental illness and mental health challenges and stress and toxic stress and socioeconomic challenges dramatically are predictive factors for people who are going to self-medicate with substances. And so when you think about how do we help people, we have to get into that whole health approach of looking at the mental health and really providing opportunities other than just treatment, but also support services, treatment engagements, more collaborations, and services in the jails, providing those resources in jail, not just waiting until they get out. A few more measurements we've come to that we're really excited about. We began to look at, when you think about engagement, what does engagement do for individuals as they go into reentry? And what we realized was, through the measurement process, and we collect a whole bunch of data, and we looked at that over the process. For individuals who engage with an IRAX peer through the 5 pilot sites versus ones who did not, you are 88% more likely to stay engaged in that first 30 days post-recovery if you've engaged with a peer in jail versus not. And we've learned that through the data. When you come to planning and think about recovery planning for individuals who are in jail, someone who has a plan when they leave the jail or leave incarceration, so that would also apply to DOC, leaving with a plan is 63% more reduction of individuals who disengage versus those who not. So you're more likely to stay engaged if you have a plan when you leave the jail than when you don't. And then the last piece of data we think is really significant is that having the IRAX program in these jails and inside the criminal justice process increased the reentry and incarcerated ecosystem around recovery across the board. SIM 1, or SIM 3, SIM 4, and SIM 2, all 3 SIM models that fall into the IRAX bailiwick were increased when it comes to recovery supports. And we've seen that with our criminal justice partners, we've seen that with our courts, and we've seen that with our justice partners, our correctional staff, and we also seen that with our recovery peers. So across the board, we were very excited to look at the data that we've learned so far, and we're really excited about wrapping up. We have about a month and a half left in the grant process, and we'll look at our final data moving into June.
Thank you, Jamie. Are there questions?
Yes, sir.
Judge?
Go ahead, Bernice. Thank you. I had a question regarding your slide on your pilot outcomes. Obviously 75%, when you're touting a 75% success rate, people are going to jump at that, particularly when we're talking about the dollars that we're spending to try and combat these issues. But my question to you is define success rate. What does that mean?
So when we measure, and when people go into reentry, we call a pre-discharge process. So when someone leaves the jail, we move them into pre-discharge, and we stay engaged with them with their recovery plan. We mark their progress through at 7 days, we have a marker that we check if they've stayed engaged at 7 days. If they've stayed engaged at 14 days, we do another marker, another report that we do on their engagement, and then we try and get them engaged to that 30-day process. During that process, a successful engagement means I stayed engaged to at least one of the markers, and I followed my recovery plan. And then once you reach the 30-day mark, then we discharge people as either successful or unsuccessful, depending on their markers and how we were able to track their progress.
Does it include rearrest?
Excuse me?
Does it include rearrest?
Yeah,
I have plenty of people who continue to remain in recovery but continue to get rearrested. And so
Sure.
what I want to know is whether or not the 30 people are getting arrested, even though they're still in recovery 30 days.
Sure.
That meeting your 75% success rate, does that include calculating people who've been rearrested within 30 days of release?
Yeah, of the ones we completed at successful at 30 days, none of them had been arrested in that 30-day period of time.
Thank you.
Although I do want to say that anyone who is rearrested and brought back into jail, if they've been in IRACs before, we have a way of tracking their recidivism. So coming back to jail, we track that, and that's marked in our system. We should have that data with our June report.
Thank you.
Bernice?
Jamie, thank you for your presentation, and the work that you all are doing is just fantastic. Just by way of sharing with this body, from a public defense standpoint, just last week, we had a CLE with public defenders in Lawrenceburg to educate and make sure they understand this program and to support their clients in it and just to be supportive. So I just wanted to share that and really share how much I appreciate you. I have two questions, though.
Sure.
You shared that for a county to be deemed ready, or a good county to have this pilot or have this program, the first thing you need is a willing sheriff. And so I had a couple of questions for you on that. When I assume most of the peers that participate and provide services in the jail have at some point been criminal legal involved, is that correct?
Yes.
And so have you had challenge, or not you, has the program had challenges finding willing sheriffs that are willing to allow peers into their jails? If so, has the program been able to educate sheriffs such that they've changed their mind and been willing to allow peers in, or have there been just roadblocks with sheriffs who just have not been willing to allow peers with lived experience in their facilities?
Well, great questions, great questions. So first and foremost, one of the things we say in the IRACS program is that having prior criminal justice involvement is a requirement, right? We laugh, say felonies are required. It's kind of an ongoing thing. Secondly, I want to say that when we first began to talk about the pilot sites, there were a lot of questions around how do you find the right peers? What are the parameters? What are the do's and the don'ts? So what we set up was we set up a pretty intensive screening process with the jail. So the peer teams, every program creates what they call a jail management team, and that has a representative from all the criminal justice partners on that team. And then what they do is they create a process in that team to screen peers for coming in the jail. So some of the questions were, can someone be on community supervision and be a peer coach in the IRACS program? And we always said that if the court was willing to have, and the probation officer felt like it was a good opportunity, and they met all the requirements to be a certified peer in the state of Indiana, which is that year in recovery, a successful recovery, and be certified and trained, then they were eligible to be an IRACS partner. We have not lost really any peers over the last year. We've lost a couple, But most of it, we haven't had any major issues or major heartaches. The sheriffs that originally did the IRAX programs were very forward-thinking sheriffs. They had good relationships with the communities, and that's one of the reasons why we chose the recovery community organizations, is almost all of them have a good working relationship with usually with the jail and criminal justice partners. So having those components of a strong recovery community organization, strong collaboration, and then a sheriff that really is willing to think about recovery in a new way and look at how his jail operates in a new way, and then having space, that's why those critical components were in place. And then the rest of it was just a matter of creating parameters. So there are parameters that would disqualify peers for operating in the jail. Most of that is decided at the local community level, but I do believe that all of our RCOs and our sheriffs have kind of all agreed cohesively that what those parameters may be.
Yeah. The second thing is probably not a question, more vision casting on my part. But when you shared that the environment, the atmosphere of the jail changes once people are recovery minded and they've been engaging with the program, that's fantastic. I mean, that's really beautiful. As I sit here, though, it struck me that so much around mental health, access to mental health care and substance misuse care happens once a person's in the criminal legal system. And just the vision cast I'd like to share is there are a lot of people struggling before they even get to that point.
Absolutely.
And I think it'd be really fantastic if a program like your program were actually even accessible to people who haven't made it to the criminal legal system, who are just struggling in their life, and if we could find a way to support people before they're arrested and charged.
Yes, totally agree. I think the great partnership, when you look at the IRAC sites, the reason we house them in the recovery community organizations is the RCOs already have peers who are working in the community, so it's already established an open door space where people can come and get help who may not be criminal justice involved yet, right? So that was the point was partnering. The IRAX program provides the team working inside incarceration, and then the RCOs already have a team working in the community, and that partnership is really, it's a win-win on both sides, and it provides a really comprehensive safety net to make sure that we can catch people before they're criminally just involved, after their involvement, and then try and keep them out once they get out. And that we found is those are absolutely critical components.
Thank you for sharing.
Thank you.
Quick question. On the CAT MHA survey results, how are you all using those results? Is that being used to start treatment while they're in facilities?
At this point, we have just been collecting information. We're still discussing, we're in discussions now with state partners on how this data could be used, how it could be utilized, but at this point we've just been trying to get an understanding of what the populations in the jail look like, and what exactly are they struggling with while they're in jail.
Senator?
Thank you so much, and thank you for your presentation. With the counties that were part of the pilot, what happens next for those counties, and how will you expand to additional counties? Because I happen to represent one that's interested.
You want to take this one, Doug? I mean, I have lots of ideas, and I mean, I think that I don't know if I am qualified enough to have the language to express the significance of the growth, the transformation in these communities around peers, around the work that peers do, and the success that they've shown. It's just been transformative. I don't know that I'm intelligent enough to really truly share the great work that these sites have done. That's why I recommend seeing them. But again, I also say that to echo Doug's statement when he started, that I believe that every county in Indiana needs this program, and also recovery community organizations. It's not like it's reinventing the wheel. We have great court partners. We have great mental health partners. We have great probation officers, and it's just adding to the ecosystem and strengthening the ecosystem in these communities and creating new opportunities. So, yeah, I would love to see this in every jail. Back to Doug. Pass it off to Doug.
So we've been having conversations with Jamie and his team, and DMHA as well as the Recovery Works team there, to understand what funding sources are available, how we can sustainably grow this. Obviously, the partnership works with the justice system because you have that really robust safety net, like Jamie said, with the community resources at our hubs or our recovery organizations. And that has to be, that collaboration has to be present in order for this to work. Otherwise, we're just providing plans and resources and education in the jails and then releasing individuals to no one's there to catch them. So I think, to me, that's the most important part, that our community organizations are ready for this on the outside. I think the jails have proven that they're a willing partner. The justice system has proven. I've been to Dearborn County twice now, and it is incredible to see the buy-in, and incredible to see all of the partners down there working together. I mean, they have a long history of collaboration in the justice system there, but it has truly kind of changed some of the thinking around incarceration and substance use disorder and access to treatment.
And I will add too, I think that one thing that we learned this year is that it's really imperative that some those foundational pieces be in place before you launch. We always say the IRAX program launches like a freight train, because it really does. Once it goes, it just goes fast. And so having that recovery community organization established in a community, having collaborations already going, and good community partners, good community peers, it's absolutely essential before you put in a program like IRAX to do that, because it doesn't, if we get people out of jail and provide those supports, if we can't hold on to them when they get out, then we're not doing ourselves a service. So we are going to be sharing a lot with people in some collaborations with IRN, some other partners throughout this year, to make sure people understand how to develop those components, and then we'll look at expanding as much as possible going forward.
Chris?
Jamie, thanks for your work. Thanks for the information. This is great. I've received good feedback from the pilot counties, and thanks for your work. I like the early stabilization of someone who's in this situation, so I like all that. My question is, can you help me understand from the physical layout of jails, are there certain jails that are not good candidates due to the physical space? Are there limitations, or is it something that could work in any jail?
So that's a great question. When we first started, I can tell you all 5 of our jails look very different. And if you go into them now, they're all still very different. Some of our sites provide services inside the pods. So they go right in the pods and work within the pods, because there's not really any other space anywhere else in the jail. A couple of our jails kind of redesignate their cafeterias as this is our group space. So the jails have been very adaptive at looking at how we can use space, because again, a lot of the jails don't have a tremendous amount of space. And then for the ones that, I mean, one of our jails say, hey, we have an empty pod that we use for reentry and for community corrections, so we're just going to take that and turn that into their IRAX place. So now when you go in that jail, the team of IRAX peers actually, so what would have been the open room in the pod is now their group room. What would have been cells before is now where they're providing one-on-one support and connection to people. So the jails have been very adaptive looking at how they can utilize space, but I will say that yes, that space is a critical component for this, as is technology. You know, having technology, the more opportunities we have with technology in jails, the more opportunities we have to provide connection, support, resources, planning, all the things that you would need to have. So those 2 components, we did have some funding. We provided them some infrastructure around technology, so they expanded their Wi-Fi's in the jail to make sure that the peers could work anywhere in the jail they needed to, and then they've done a great job of utilizing space. But I really feel like that no matter, with a few exceptions, if someone has literally no space whatsoever, I think it would be a big problem. But our peers have been really good about finding opportunities, and so have our sheriffs at creating good opportunities for this. So it's a great question.
Good, yeah. Thank you.
Representative?
When somebody is diagnosed with a mental health disorder, are they able to receive medication? Is there somebody that can provide them treatment in the jail?
That's a great question. So each of our jails have a medical provider that's assigned to them, and it's a little different depending on where they are. Our peer coaches don't do anything along the lines of treatment. We just provide support, recovery and support. So we do have a medical provider in the jail that does look at, the sheriffs and the jails do look at medication and what medication needs may be there. I can tell you that our peer coaches are, each team has a resource navigator assigned to the team, and their job is to make sure that all the treatment recommendations, referrals, as far as, well, not recommendations, but all the referrals that need to be in place for someone leaving the jail, like any kind of medication, their doctor follow-up, treatment follow-ups. We're putting all those referrals in place before they leave, according to what they decide that they really want to do. But in the jail, the medical staff provides all the support for medication and anything that they would need while they're there.
Devin.
Thank you. Jamie, thank you very much. As we look at this, obviously you've been fairly successful with the adult population. I know we've had a conversation previously, but I'd be interested in see what the capacity would be to maybe expand to juvenile populations. As we know, they've got a pretty large substance abuse issue with our juvenile populations, especially within our correctional settings, custodial settings, whatever. What would need to happen to the program, I guess, to maybe establish a juvenile program?
Well, I think that, when it comes to the actual scope of the science behind reentry, like helping someone transition and have support, providing those supports for youth is dramatically different than providing those supports for adult. Many of that wraps around consent. The second side of that is the last 3-4 years, we've been really blessed here in Indiana. The governor's office and our state partners have invested in what we call a recovery community ecosystem across the state. So I will say that the process of expanding that ecosystem into the juvenile world, I think, is ongoing. I don't know that I feel like we're really there yet, but it is ongoing. But if we can get to the point where we have the right infrastructure in place as far as a training program for peer coaches and a way to provide peers for youth, opportunity to certify those peers to ensure that they can adequately provide services for youth in a way that's reflective of the needs of the youth, and then an opportunity to manage and supervise those teams and collaborate with our treatment partners, I believe that we would be able to utilize a program like IRACS to help with reentry and support and community-based support for our youth and transition age youth especially. We see a lot of transition age youth people in the jails. Some of our IRACS programs have helped people graduate. We just helped somebody graduate just a few months ago while they were in jail. So I think that there is opportunity there to expand and look at the science behind IRACS and apply it to the youth and transition age youth population and their families. But I still believe we still have some infrastructure to develop around that. I know our state partners are already working on those things, but I don't know that I can completely define where we are with that just yet.
Yeah, we've had some of those conversations around how different the program might have to be in order to deliver services to children. But first, that infrastructure that we've built around adults and mental health and addiction has to be in place, and we're not there yet. Well, thank you, Jamie.
Thank you very much.
The report that Jamie mentioned is in your packet. I'll also point out that there's some really great data in the report around fidelity to the model. Really demonstrates that when IRACS is fully implemented from the beginning, you get really great results. So appreciate Jamie's and his team really looking at the data and ensuring that we're implementing something that is supported by the evidence. So next, we have Shelby Neerman from the Department of Health. Shelby oversees the overdose surveillance systems and is an epidemiologist who's always looking ahead and, again, analyzing our data to help us understand where our emerging threats are. So, Shelby?
Hi, everyone. My name is Shelby Neerman, and I'm the Overdose Surveillance Systems Epidemiologist at the Indiana Department of Health. And today I'm going to be talking about the emerging threat of xylazine in not only Indiana, but across the nation. So on April 12th, 2023, Dr. Ruul Gupta, Director of the White House Office of National Drug Policy, officially designated fentanyl adulterated or associated with xylazine as an emerging threat to the United States. The administration outlined that while national overdose numbers have flattened or decreased over the last several months, that xylazine does complicate the efforts and threatens progress that's being made to save lives and address the opioid crisis. So xylazine is a non-opioid tranquilizer used in veterinary medicine for its sedative, analgesic, and muscle relaxant properties. Xylazine was first approved by the FDA in 1972 for sedation and pain relief to perform surgeries and other medical procedures in cattle, horses, sheep, dogs, cats, or other wildlife or zoo animal species. So those solutions are prepared by the veterinarians to be administered based on the weight and the size of the animal. So there are no approved uses of xylazine for use in humans, and clinical trials in humans were discontinued due to the severe effects, with doses anywhere from 40 milligrams to 2,400 milligrams causing toxicity in humans. In recent years, xylazine has increasingly been detected in illicit substances such as heroin, fentanyl, meth, cocaine, and benzodiazepines, which does result in a dangerously potent substance that increases the risk of overdose and death. Reports from social media and news outlets do suggest that xylazine-containing products may be sold under the street names Trank, Trank Dope, Sleep Cut, or Philly Dope. And these users may ingest xylazine in a number of ways, and that can include snorting, smoking, or injecting. While xylazine may be used intentionally or unintentionally, more commonly it is adulterated into the drug supply unknowingly, and individuals may not be aware of xylazine's presence in the drugs that they have. Xylazine test strips, they do function similar to fentanyl test strips, have been developed, but are not yet approved by the FDA to be marketed or used in clinical settings within the United States. Xylazine does have a rapid onset with effects occurring within minutes, and it has the potential to last more than 8 hours, definitely concerning, and that can be depending upon the use, the dose, and the combinations of drugs that the user has taken. Within humans, common clinical effects of xylazine could include low blood pressure, heart rate, arrhythmias, hyperglycemia, skin lesions and necrotic ulcers, unconsciousness, drowsiness, and coma or death. The development of skin ulcers and wounds is commonly associated with xylazine use in humans, and these ulcerations are often severe and painful, presenting with necrosis or black scars. While these ulcerations are most commonly seen in persons that inject the substances containing xylazine, they can present regardless of use type, and they may develop in areas distant from the injection site. Xylazine in combination with opioids or other central nervous depressants such as alcohol or benzodiazepines increases the risk of an overdose. It is important to note that xylazine is not an opioid, and that naloxone administration may not be as effective at fully reversing a xylazine overdose. However, when an overdose is suspected, we always encourage that you should use naloxone. In the case of a suspected overdose, administer naloxone, call 911, and perform those life-saving measures. And additionally, opioids are almost always present in cases of overdose in which xylazine is present, and while naloxone may not reverse the effects of xylazine, it will reverse the effects of those opioids. So this data was all taken from an article written by Fredman et al. In 2022, and within that article there is some collection of data across 10 jurisdictions representing all 4 U.S. Census regions, and across that there was a 20-fold increase in xylazine overdose deaths from 2015 to 2020, with a total prevalence of 0.36% of deaths involving xylazine in 2015, and then by 2020, that being at 6.7% of overdose deaths involving xylazine. In 2020, the highest prevalence of xylazine was observed in Philadelphia, Pennsylvania at 25.8% of deaths, followed by Maryland at 19.3% of deaths, and Connecticut at 10.2% of deaths. And then across those 4 census regions, the Northeast had the highest prevalence of overdose deaths involving xylazine, and the West had the lowest, so there may be a correlation with the drugs moving from the Northeast to the West. Among the jurisdictions with a substantial number of xylazine deaths and where full drug overlaps could be assessed, including Connecticut, Illinois, Alabama, and Pennsylvania, fentanyl was present in 98.4% of xylazine-present overdoses. In their published public safety alert at the end of 2022, the DEA also indicated that seized xylazine and fentanyl mixtures were found in 48 out of the 50 states. And then finally, the DEA laboratory system reported that 23% of fentanyl powders and 7% of fentanyl pills seized contained xylazine in 2022. Within Indiana, from 2020 to 2023, 322 decedents have had a positive toxicology result for xylazine. The number of positive toxicology results for xylazine has increased since 2020, with a substantial increase you can see from 2020 to 2021. And these numbers likely undercount the true number of positive toxicology results for xylazine, as there's no specific time frame in which coroners are required to submit their results to us. And additionally, while xylazine is a required substance on the IDOH toxicology testing panel, coroners are not required to use that testing panel, and so if they use a different one, they may not be testing for xylazine in their overdose cases. So in addition to toxicology data, one thing that I do at the Indiana Department of Health is I monitor real-time ED data for spikes, clusters, and anomalies in drug overdoses that occur across the state. So on average, this data is available to us within 3 hours of an emergency department visit that involves an overdose. And it does have its strengths and its limitations to its use. It does provide us access to that data to monitor and respond to suspected overdoses in near real time. But unfortunately, toxicology testing is not often done in the ED, so we don't necessarily know what substances are being involved in these overdose cases. IDOH does utilize those chief complaints and triage notes that are found within those ED visits to help us identify new or emerging drugs, one of those being xylazine, and this data source has allowed us to access less than 5 indications of xylazine in our non-fatal ED data. I know that this is very hard to see, but I will explain it. The data in this image includes toxicology results from decedents with a date of death between January 1st, 2020 and December 31st, 2022. The Axis toxicology data set is composed of the results depicted in toxicology reports that are generated from the IDOH testing panel that each coroner requests per decedent. It is important to note that some coroners submit toxicology reports to other laboratories, and those are not reflected in this data set. And the data provided in this is preliminary, and the values are subject to change due to aggregation of analytes or metabolites that are performed, as well as county-specific data as it is finalized. These results were reported from 87 of Indiana's 93 counties, and Franklin, Grant, LaPorte, Ohio, and St. Joseph were not included. So of the 289 positive toxicology results for xylazine from 2020 to 2022, 93 or 32% of decedents tested positive for both xylazine and fentanyl. Additionally, 90 or around 31% of decedents from 2020 to 2022 tested positive for a combination of xylazine, fentanyl, and meth. So in conclusion, xylazine is being adulterated into the illicit drug supply across the United States. The expanded use of xylazine as an adulterant may be driven in part by its low cost and profit value for traffickers. The emerging presence of xylazine does complicate overdose response, and it requires a nuanced approach across public health, public safety, clinicians and providers, treatment, and recovery. Specifically in acknowledging that xylazine overdoses may require additional life-saving measures, not only in immediate response to the overdose, but in caring for those xylazine-associated wounds and symptoms that occur following those overdoses or use. The prevalence of xylazine is likely underreported both in its geographic distribution and its contribution to both fatal and non-fatal overdoses across the United States and throughout Indiana. So just wanted to pause here to highlight some resources. If you have any interest in looking more for additional overdose data or naloxone information or resources, you can visit the following sites. And then we do have 2 grant opportunities for qualified agencies to receive opioid rescue kits, one for our local health departments and one for our rural responders. And then as of March 29th, naloxone is now available as an over-the-counter medicine, so that is something that we are excited about. And then, does anyone have any questions?
Questions for Shelby?
Nicely done, Shelby. Thank you so much for the data and the information. I should probably know the answer to this question, but does purchase of this drug require a DMV or a Doctor of Veterinary Medicine license to get this? Does anybody know that? Or is this just all illicit drugs coming from Mexico or other places where they're getting
So
this?
I can speak to a little bit of that. So I actually grew up on a farm, and so I talked to my dad about xylazine and its use on our dairy farm, and he mentioned that if any time this drug is used, a veterinarian will come out and either give that to the animal, because it's most often used if they are going to perform a surgery or it's being used for pain relief. So most often they'll come out, give the drug, and they take that away. Now, in terms of where it's coming from in Indiana or across our country, I would assume that it is coming from out of the country.
And we were on a call with the Office of National Drug Control Policy a couple weeks ago. They don't know.
Okay. I mean, are they regulated like we're regulated for prescribing this information? So we would know if a vet was getting huge number of prescriptions in our state or something, correct?
Ideally, that's correct.
What'd you say?
So I don't know if we know, but they have a regulatory.
Okay.
Yes, yes, and that's why I think we don't see that in the data, and so that is why there's a thought. But we're also, I don't believe they're really seizing a lot of it either, and so they're at this point unclear as to where it's originating from.
Okay, thank you.
One just comment. Since xylazine also has a withdrawal secondary to it, I don't know if there's data or if there's information on this making opioid withdrawal particularly worse.
Yeah, there is a little bit of research surrounding the withdrawal, but not a lot. There's just not a lot of research around xylazine. But what we do know is that it does have a withdrawal, and it is likely pretty severe. And so what that looks like in combination with opioids, I'm not sure, but I would assume a pretty severe withdrawal.
Shelby, I don't mean to put you on the spot, but overall overdose deaths in Indiana, are they going up or going down?
From our provisional data that we have available, it does appear that the drug overdose deaths decreased by about 20% from 2021 to 2022. So that is a positive. So we'll see what happens in looking at that data as it is finalized, and then from 2022 to 2023.
Thank you.
And Chris, we expect to have those official numbers from the CDC probably in June. Historically, that's when they release them. Well, thank you, Shelby. I just want to reiterate 2 points. One, if you suspect an overdose, administer naloxone, call 911, as xylazine is usually being mixed with opioids. And then also, as a reminder, we have made naloxone available through our extensive network of 18 vending machines, 430 nalox boxes, over 200 grassroots distributors. And we're actually going to be in Evansville tomorrow announcing our final nalox box. So exciting stuff there, but naloxone is available. Or call Justin and she will mail it. So shifting gears, I'd like to call up Amy Duke from FSSA and the team from Williams-Randall to present on the next phase of our Know the Facts campaign titled See Beyond the Addiction. If you recall, the Know the Facts campaign is, an anti-stigma campaign is required as part of our state opioid response grant from SAMHSA. And last update came from Jim Gavin, who has since left FSSA, but Amy has come on board. She is kind of solely dedicated to working with DMHA and has done a great job of helping align the messaging. We've also brought on a new team to help us with the next phase of Know the Facts, so we're really excited about where the campaign's going. Amy?
Great. Well, thanks for having us here this morning. Appreciate the time. So yes, my name's Amy Duke. I'm the Marketing Program Director for Indiana Family and Social Services Administration. And today, along with our partners from Williams Randall Advertising, we wanted to provide an update on the stigma reduction campaign known as Know the Facts. A little brief history. Back in 2017, FSSA and DMHA started work on a stigma reduction campaign focused solely on opioid use disorder. And then in 2020, that campaign was widened to include substance use disorder. So it went from Know the OFACs to Know the Facts at that time. Throughout both of those phases of the campaign, there were 3 messages or 3 facts that were used to help build that awareness and help reduce stigma. And that was addiction is a disease, treatment is available, and recovery is possible. In October of this past year, we started work on redeveloping this campaign and put out a request through the QPA process to bring on a new agency to work with us in redeveloping our strategy around it. So we started work with Williams Randall in October and have since redeveloped what the campaign focus is. While those same facts are still important in the campaign, we wanted to put together a new call to action that tells a little bit more about what the campaign is focusing on to let the audience know that it is about stigma reduction. So I'm going to invite our partners up here from Williams Randall, who's going to walk you through the new phase.
Good morning. My name is Emily Matherly. I'm the Director of Client Services at Williams Randall Advertising, and I would like to share just a little bit of information with you about where we were headed with our campaign strategy. When we began working with FSSA on this very important campaign, we started our process much like we start all of our processes, especially when we're dealing with a very complicated messaging strategy, a very emotionally charged subject matter. And we go into every bit of data, every bit of research that we can possibly get our hands on to understand the scope and the scale of the problem. I do want to admit that probably like most Hoosiers that are not directly related to prevention and recovery, we found ourselves woefully naive about the scope and scale of the problem. We found it to be very educational, and I am very proud to say that our agency leadership was very open with our team sharing our own personal experiences that we have had with stigma and that we've had with substance use disorder. And where that led us was to a team that was very compelled and felt very compelled to help contribute to solutions to this problem. So as we dove into that research, we developed 3 key insights that really drove our messaging strategy. The first of which that I'd like to share with you is really our first indication that awareness does not actually mean that somebody is going to believe what we are telling them or is not actually or necessarily going to result in someone changing their opinion. And by doing that, we got to that conclusion by reviewing some awareness research that was done within the state of Indiana, but then also reviewing Shatterproof's 2022 SASI research, where we learned that 80% of people in Indiana had some familiarity with the statement that addiction is a disease. But on a national level, Shatterproof reported that less than 25% of respondents actually believed that substance use disorder is a chronic disease. Really just giving us this first indicator that awareness of the facts needs to be supported in other ways in order to get people to understand what is behind this disease and to allow them to have that sympathy and replace that stigma with support. Our second key insight is really an evolution of the first, or continuation of that thought, if you will. And that is that we have to take very specific steps and deliberate messaging strategies, or put deliberate messaging strategies in place in order to be able to change minds. That it is not enough just for us to use tactics to increase awareness, but we needed to use messaging strategies that allow people to just open up their mind a little bit, take what they know, and see it from a different point of view, and give them an opportunity to see something in a different way. It's clear, I think, to all of us that the only person who can change your mind is you. So the expected outcome from this messaging is not an immediate, yes, I see how I can see this differently, and now I have changed my opinion. But we want to introduce different ways of looking at a situation so that the next time they are in a conversation, or the next time that they are confronted with an opportunity that they can choose different words, that they can change the way that they talk about the situation. Our third key insight had to do with the idea that stigma is a barrier to treatment. It's incredibly impactful for people to know that, or for all Hoosiers to know that people are afraid to seek treatment for fear that they will be judged, lose their job, lose their children, or worse. And that the way that we speak about this and the way that we treat people actually contributes to this. What we wanted to do as well was focus specifically on that. We want to focus on ways that we can get Hoosiers to express sympathy and express hope and support at the point when a person is seeking treatment. And that we needed to just be very specific and focus on that point within the journey. Okay. So with that, we actually did jump into the process of executing proprietary research along with FSSA and Next Level Recovery. We conducted quantitative research with over 1,000 respondents within the state so that we could measure perceptions of substance use disorder and learn more at the level of the shatterproof research, but specifically within the state of Indiana, over-indexing for individuals in rural communities and racial minorities and minority groups. We also conducted qualitative research in the form of online focus groups to test specific messaging for effectiveness so that we could adapt those as needed. And I would like to share with you just a few of the key research findings few of the key findings that we had as a result of that research. The first key takeaway was that there is a significant need to establish the general public as the audience for the message, not just those with an SUD or a loved one helping an immediate family member or friend to seek treatment or to get into active recovery. A lot of the messages that we tested, people immediately excluded themselves from the audience. And they said, I don't have a substance use disorder. I don't know of anyone. I'm not helping anyone, so this message isn't for me. So we needed to be abundantly clear that this is a call to action for everyone, not just for people who are dealing with this situation immediately. The second challenge was to make the audience understand that this is not a say no to drugs or a treatment message. We have been blessed with over 40 years of just say no. And this is what your brain looks like on drugs, and really, really compelling messages and effective tactics to get that message across. But this is a different message. And when people start to hear words about substance use disorder within a spot, they immediately associated that with an anti-drug, don't use drugs campaign. We needed them to listen to our message to really be able to take it in. I also wanted to share that 78% of our respondents said that substance use disorder is common in their local community, and 56% said that they know someone affected by SUD. 70% of respondents agreed with the statement that addiction is a disease, but willingness to associate with a person with an SUD was much lower. So these are similar questions of what you would see in shatterproof research, but on a statewide level, so looking at Hoosiers only. You can see that in asking people how willing would you be to have a person with an SUD as your supervisor at work, have a person with an SUD marry into your family, hire a person with an SUD to work for you, all of those index at less than 30%. So while we do have this high level agreement that addiction is a disease, how that is translating to stigma and how that is translating to behavior is leaving a significant disconnect. It was something that needed to be addressed, and these types of metrics are what need to be measured again so that we can look at the effectiveness of this campaign. I do want to just anecdotally say that there has been a lot of aha moments about the idea that addiction is a disease. In one of our virtual focus groups, we had a respondent, when we asked the question, do you agree that addiction is a disease? And she adamantly said, yes, it absolutely is, it is a disease. And so in a one-on-one chat, we asked that respondent to expand upon that and to share how she adamantly believes this, and maybe we could get some additional insight. And the insight we gained was not what we expected, because her response was, when we asked for additional information, was, yes, addiction is a disease because it does not just impact the person who has it, it impacts everyone around them and has a negative impact on everyone. And metaphorically speaking, she is absolutely correct, but in the literal sense that we want people to understand that addiction is a disease, she could not have been further off. So just how people define the disease, how people accept this information is very different, and we can't make assumptions that having that awareness is actually going to change their opinion or change their behavior even. Okay. So now I would like to have Julia Roberts, my colleague, come up, and she's going to share some samples from our creative with you.
So I'm Julia Roberts. I'm an account executive at Williams Randall, and I worked on this campaign. And for this campaign, our call to action is See Beyond the Addiction. It's really a challenge for all Hoosiers to see their loved ones, their friends, their neighbor, their coworker, anyone in their life to see beyond their substance use disorder. It's also a challenge. It's giving people something to think about when they're thinking about substance use disorder. If we want to move from awareness to actually changing minds, we need something for people to think about when they see our creative in the market. So we took this call to action and put it into the creative that's in the market. So we're going to show you 2 videos here in just a second. One is the perspective of someone living with a substance use disorder and how there's more to him than his addiction, and then one about the perspective of a mother whose daughter has a substance use disorder. And so really these are strong messages to show that there is more to them than their addiction. So I'm going to play these, if this will play.
I'm a grandson, a son, I'm an employee and a mentor. I'm a father to 2 beautiful kids and a husband to an amazing wife. And I have a substance use disorder. In other words, I'm living in recovery with an addiction. And now that you know, will you let it change how you see me? It's okay to see my addiction, but I want you to know, it's people choosing to see me as a person that changed my life.
See the person, not just their disease. Learn more at cbeyondtheaddiction.org.
And then there's the second one. There we go.
I had changed the locks, didn't even know where she was living. And then one night she calls to say she's getting treatment. Can I drive? I almost hung up. But then I thought, that's my kid. I chose to put away the hurt and the fear and just see my girl.
Addiction is a disease. Standing by a loved one as they fight it will test your faith, patience, and sanity. But it's possible when you see the person, not just their disease. Learn more at cbeyondtheaddiction.org.
All right, so we carry this message over into other mediums. So here you'll see what is traditionally thought of as an outdoor board. So you may see this on the highway, driving to work. And we're putting a message out there that makes people think, do you see me or my addiction? With, again, the URL for the microsite. Here too, see the person, not the disease, driving home this message of having people think about what they know about substance use disorder and trying to break that stigma. And then something we're doing that's unique to this campaign is we're doing something called programmatic digital out of home. So you saw what was that traditional outdoor board you're seeing on the highway, but these ads will be on screens across the state of Indiana, over 7,000 screens. And when I say screens, I mean you're at the gas station getting gas and you see some of the ads playing. Our ad could appear there. In convenience stores, in grocery stores, restaurants, gyms, the mall, anywhere, because we really want to reach people where they're at. So like in rural communities, for instance, not everyone's driving into town or into downtown Indianapolis and seeing these billboards. So we want to reach them where they're at when they're checking out at the grocery store to deliver these important messages. We also have the QR code on there so that if people are checking out, they can quickly scan it to land on our microsite. So speaking of microsite, this is the destination landing page for our ads and the page for Know the Facts. So we not only updated the look and feel of the page, but we also updated it with updated information, statistics, numbers, everything. So this is completely refreshed. And we know the 3 facts for Know the Facts are integral to the campaign. This is what people have come to know the facts by. So these are still prominently shown on the page. You can see here, addiction is a disease, treatment is available, recovery is possible. And all of these click off to their own dedicated subpages, which you can see in the navigation on the top left. On these pages, there's educational information, resources, statistics, everything. So as people see our ads in the community, they click on them, they go to our site, and they're curious about what this means, they can actually learn more. A big thing here too is we have a 5 ways you can help, because we want to give people tangible ways that they can get involved in this campaign, how they can change their stigma around substance use disorder. And if I keep scrolling, you can kind of see more of this page. On here, you can see the on-screen talent from the TV spots reflected here nicely on the site. We want that brand cohesion, so if somebody's seeing our ad on TV and then they click one of our Facebook ads, they know they're in the right place, and they can learn more about our campaign. And then this is just the rest of the homepage. Like I said at the top, there's a lot of good sub-pages that talk about our campaign and really try to educate people as we put this message out in the market. And our campaign does not stop here. The FSSA team is continuing to push this on, so I'm going to pass it back over to Amy.
Yes, so now that Williams Randall has done the research, redeveloped the creative, launched the microsite and the advertising, our next steps will be to develop our PR and outreach strategy, and going back to reaching individuals where they are. We're really working with grassroots organizations and those who may not have traditionally been engaged with the previous phases of the campaigns, just to try to engage with those individuals where they are. Any questions?
Questions? All right. Well, thank you very much. We'll now turn it over to Devin from ICJI for an update.
Thank you very much. I'll be pretty brief here. Just update kind of on where we are with the local coordinating councils around the state. Currently, CJI is working on our end-of-year report for our 2022 calendar year for the comprehensive community plan, so hopefully to have that later this summer for the committee's review. I can say as of May, beginning of May, earlier this week, 91 of the 92 counties have successfully submitted their 2023 plan, which again is fantastic. It's the first time in a very long time that that's happened. We have one county in eastern Indiana that we're working on to reactivate the LCC, and then they'll be up to speed. Also working on a survey, some results from a survey that we had sent out to the LCCs. Was recently completed. Some of the findings are pretty interesting that we've from the survey. 57% of the LCCs claim that they have a pretty good view in their community and seen as a valued asset, which is up by about 12% from the prior survey, which is really good. Happy to see that. 43% of the LCC said that their local drug problem they rated as severe, so I think that's telling. I know we're doing a lot of work at the state level and across the state, but obviously substance use issues are still pretty pervasive. The other 57% rated their issue as moderate, so that, again, that's still fairly telling that at least in those communities that issue is pretty prevalent again. About just over two-thirds, or about a third, a little over a third, said they had no issues with funding in their programs. About 60% said they did. Most of the issues with the folks that said they have issues are not necessarily funding, although funding is always an issue, but lack of quality applicants at the local level was a big issue. And so that's something that I think we need to continue to work on, work with partners and develop those infrastructures that we've talked about previously. And most common partners that people outlined in the surveys were obviously law enforcement, education, and treatment were the biggest partners in the community. So that's about it, really. Just quick update on that. A lot of the LCCs are continuing to work with the opioid settlement. Some of them are very active at the local level with that, so very happy to see that as well. Thank you.
Thank you, Devin. Any questions? All right, well, before we adjourn, I just want to provide a brief update on the opioid settlement funds and the matching proposals. As all of you recall, in January, we put out a request for proposals with the goal of helping communities and counties collaborate and build connections to the infrastructure that we've put in place and to implement evidence-supported programming. We received 78 applications requesting over $93 million. And that was communities dedicating almost $29 million in matching funds. So there was a significant amount of competition, as we only had $25 million to match. The proposals had a wide range of requests, and there were many that were working to coordinate on a regional basis, so that was very encouraging. Our team was able to mine the proposals for data and trends, and that, again, will be helpful in the future. There were quite a few areas where there was a broad disparity between the funds requested and the services being rendered among the proposals. So for recovery residences and peer recovery coaches, we have made the decision to pull those items out of the proposals and will release separate proposals for both of those. This will allow for streamlined guidelines and guardrails, more commonality and purpose, and will ensure oversight and reduction in waste. All applicants were notified of the state's decision on Monday and have been instructed not to make any public comments or announcement until after the state has made a public announcement, which is to come. I do want to thank the review committee. We had members of the the Division of Mental Health and Addiction, the Department of Health, and many of your staff around the table helped consult and field questions as we worked hard to make sure that we had proper background on the proposals, that we weren't duplicating efforts with other funding streams. We had a lot of questions around DCS and a lot of justice involved programs as well. So stay tuned. There will be a more formal announcement of awardees later this summer, and there will be more proposals to come, and those will be released through the DMHA funding website. And finally, I want to thank Terry Stigdon for her work with the commission and helping the children of our state. Tomorrow is your last day? Yeah. So join me in thanking Terry for her. For 5 years here, so thank you.
Thank you.
So thank you to all the presenters today. I appreciate everyone's time and attention. And our next meeting is August 3rd at 10 a.m. here at the Indiana State Library. We stand adjourned. Thank you.